Okay, so thank you all for the opportunity. I got a little nervous because I was like, I didn't see the Zoom link. So I was like, uh-oh. But it came through in time. So I know I don't have that much time, I think probably about 10 minutes or so today. But what I'm going to do is go ahead and share my screen and then kind of give you a shortened version of the PowerPoint presentation, and then the more complete set of slides can be found on our webpage on paid family medical leave. So what I'll do is go ahead and share my screen, in which everybody can see. So we'll go into slideshow mode and go from the beginning. So assuming everybody can see it, I'll go ahead with just a general overview. So last year, Governor Mills and the state legislature enacted paid family medical leave, which made us one of 13 states in the country to adopt kind of a state-owned or state-run paid family medical leave program. The program is going to provide up to 12 weeks of paid leave for either family, medical, safe leave, or leave that's related to a family member's upcoming military deployment. And this is a broad reaching law, meaning that it's going to cover many employees and employers in the state of Maine, with the exception of the federal government, and that's more of a statutory exemption for those employees. But to move forward with the reasons to take leave, these are just general examples here. So obviously for family leave, you can take it for individuals who are looking to expand their families, either through birth, adoption, or fostering, or to care for a family member who may have a serious health condition. For medical leave is to care for your own medical needs. So it's the employee tending to that. And then for safe leave is to either help the employee or the employee's family member stay safe after abuse or violence. And then finally, as we said before, individuals can take leave for a family member's upcoming military deployment. So here's kind of what to expect in 25 and 26, because a lot of people have been asking us, understandably, all of the aspects of paid family medical leave. But with this slide, we can hopefully help the public kind of sort through, what's coming up soon versus what's coming up down the road. So in 2025, there are a couple of things that are going to be happening. And the first one is employees will begin to see that 0.5% deduction come out of their pay for paid family and medical leave. And then along with that, and this is something the department has to do, is to adopt rules for the program. So we are making a ton of progress, and I'm pretty confident that we will be able to meet that January 1, 2025 statutory deadline to adopt rules for the program. Also coming up in early 2025, more likely in January, and this is something that employees do not have to worry about, but employers do, is the launch of the Maine Paid Leave Portal. And that is where employers in the state of Maine will register for the program, and then they'll do a self-report on how many employees they have. This is also where they'll pay their premiums and file the wage reports. And then finally, in May of 2026, the benefits will go live for the program. So to kind of help, and again, I was trying to figure out, out of all the slides, what was going to be more important. And I think talking about the financing of it, certainly going to be on people's minds. So to talk about the premiums and how it's going to be paid for. So essentially, there will be a 1% premium for this program that will be split between the employee and the employer. So both parties have a stake in this process. Individuals could elect coverage, so you can opt in if you are a self-employed individual or a tribal government. And if those entities do opt in, they'll be paying 50% of that premium rate. But we kind of wanted to help both, mostly employers, but also employees kind of help figure out what is 1% and what does that look like. So we said that for employers with 15 or more employees, it will be a 1% premium that is going to be split between the employee and the employer. So for employers of this size, the employer will be paying 0.5%, and then all of the employees will also be paying 0.5%, equaling 1%. And then we said for entities under 15 employees, that premium rate is going to look a little bit different. So for employers of this size, the most that entity will be paying is 0.5%, which can come entirely from employees' pay, or the employer could choose to pay that amount on behalf of the employees. And that also applies to businesses with 15 or more as well, because we've gotten a lot of questions around, I'm an employer, I'm just going to pay the full 1%, which includes the employee's portion of 0.5%. So that is something that can be done, or again, it can be taken out from their pay. We wanted to kind of help break down what the premium amounts are. So again, in January and going forward into 2025, people are going to start to feel that payroll deduction come out of their pay. But we wanted to kind of break down based on individuals' salaries, and these are just general examples. So as you'll see, for someone who's making about $35,000 a year, looking at the 0.5% premium deduction, they should be paying no more than $3.36 a week, or $175 a year. And then you'll see, again, the premium breakdown per week for the other two income scales. I will say for this program, and this is also required by law, that the premiums that are coming out of people's pay are capped at the Social Security wage limit. So, and that changes every year by the Social Security Administration. So people should be paying no more than that annual amount for paid family and medical leave. And for whatever reason they do overpay, they could be entitled to a refund. So to kind of hit on the eligibility requirements, because there are for this program. So employees generally must give some form of reasonable notice to their employer on their intent to take leave or to schedule leave. And there is also an exception for emergency notice. So that might look a little bit different. And most of these things that I'm talking about now have been spelled out into the rule in terms of what is reasonable notice, what happens in situations where there's an emergency for notice. But again, generally employees must give notice to their employer. There will be proof that you have to, demonstrate in order to qualify for leave. So it just depends on the type of leave. If it's for medical leave, that might require, different type of certification versus another type of qualifying reason to take leave. But we're hoping to spell most of this stuff out later in process, especially as we get closer to 2026. But there's also an earnings requirement associated with this program. So essentially, individuals must be earning income. So someone must be earning no more than 6 times the state average weekly wage in 4 of the last 5 quarters. So we're looking kind of over that time period to see if you've met that monetary requirement. The state average weekly wage is something that does change on an annual basis, and the Department of Labor will announce that every year. So what you see here as the state average weekly wage for 2024 may look different in 2026 when individuals are starting to apply. And then finally, when it comes to the notice piece, undue hardship, that is part of our statute. And it is something that, I think employees and employers are going to have to navigate through, because this is, Maine is the only state in the country to have this term undue hardship in our paid family and medical leave law. But I'm happy to answer any questions about that. But we do have it also spelled out in rule on how to navigate through that in order to avoid making sure that the employee, has the time that they need to schedule leave versus what the employer's needs might be, when they're trying to assess whether undue hardship applies or not. Again, I cut out the previous slide to this one, but there is a benefit associated with this program. But I wanted to highlight the focus on this one to help people break down what is the benefit amounts and how much. But essentially, when people are applying for the program, we're going to be looking at their individual weekly wage that they earn. And so that could be wage data that either the department has on file or information that they provide to us. But as you'll see here, for someone who's making about $35,000 a year, their weekly wage should be about $673. We have to calculate their benefit amount at tier 1 and tier 2. And as you'll see from tier 1, on any earnings up to 50% of the state average weekly wage, they're going to be earning about $514. And then if they're earning more than 50%, we have to calculate that too. So in this case, someone who's making $35,000, they should be making no more than $580 for the time that they're on leave per week. And as you'll see, the numbers do change the more that you earn. The benefits are for this program capped at the state average weekly wage, which again is a number that is subject to change on a yearly basis. So in 2026 and beyond, when individuals are applying, that cap number may be different. And then some things to also be thinking about, especially if you are an employee. So there are job protections surrounding this program. So if you are an employee that's worked for your employer for at least 120 days or more, you are entitled to return back to that job after taking your leave. And these benefits are also portable, which means that, we know that employees work more than one job in many cases. So if an employee does go to another employer that's part of the state plan, you won't necessarily lose your eligibility. When I mean eligibility, you still have to apply for the program, but just because you leave employers does not completely take you out of potentially being eligible for paid family and medical leave. And then again, we wanted to affirm that, employees won't be able to apply for PFML until early 2026. And we're thinking about that now in terms of what that process is going to look like. And finally, these are some things that we encourage folks to do, both employers and employees, is to visit our webpage. And we do update this webpage as often as we can. It's based on the information that we know. And because we're in the implementation mode, information does change. So we try to make sure that we let the public know about those changes. So that's where you can find recordings on any webinars we've done on PFML. You can find a frequently asked questions document as well. So again, it's a one-stop shop to get as much information about it. And then we also encourage folks to sign up for the interested parties list. So one example was yesterday, we told folks on that list that we updated our FAQ that reflected on collective bargaining agreement. So we are using this as a pretty frequent channel to let the public know, hey, we have some information out about paid family medical leave. If you have a moment, please review that information and reach out to us if you have any questions. And then finally, review information. So we do have information available in 8 languages, I will say now, because we are, again, evolving in our information. We have our FAQ up in English currently, but the other 7 we don't have translated yet. We're in the process of doing that just to make sure our information is accurate, across the board. So with that, I'll stop sharing my screen and see if folks have any questions. And hopefully I didn't go beyond 10 minutes. I have, but
you're fine, Reggie. Any quick questions for Reggie? And Reggie, we can bring you guys back. Also knowing that this was really helpful information for folks to know what's happening in January. And then definitely we'll want to bring you back as you all work out the process for having folks sign up for family medical leave. And then also as decisions are made about what the benefits are going to look. I mean, more information about the benefits will be helpful in the future. So thank you so much for that overview.
All right, you're very welcome.
Great.
Thank you.
Seeing no questions, I'm going to turn us over to Sheila Nelson from Maine CDC, who's going to give us an update on the Maine Integrated Youth Health Survey and where they're at in the planning processes for the next survey. And then Sheila, you can just jump into your update on, the where we are with school-based health centers, with the increase in funding that was a partnership between the Department of Education and DHHS. There was some ARPA funding to expand school-based health centers. Maine CDC was able to find funding for this current school year. And so Sheila's going to give an update on where things stand with the funding, with the ability that they've had to be able to expand some of the funding for school-based health centers, at least through this current school year. So Sheila, let me turn it over to you.
All right. Well, I can do a MIAS update that's pretty quick and just verbal. So we are midstream for the 2025 administration of the Maine Integrated Youth Health Survey. It gets administered in the spring. I use air quotes because it's February and March of the odd numbered year. So this is a school year where we will be doing an administration. We are very actively recruiting. The good news is that we actually have a number of counties where we have 100% participation for both middle and high school, which is just amazing. We're super psyched about that. We do have a few where we're struggling a bit. So Aroostook County folks, or if you have connections to Aroostook County, that's an area where we've unfortunately had some drop off in participation. It makes it difficult for us to give them county level data, which is a bummer. And also oddly, Kennebec County. We need to pull in a few more middle and high schools for Kennebec County. So if you have contacts in a school, if you have a kid that goes to a school, let me tell you, your power as a parent is big. Generally, if you just sort of have connection to those schools, please advocate for them to participate in the survey. It makes a big difference. In the next month or two, letters are going to go out to parents of the schools that are choosing to participate, letting them know the survey is happening. Parents then have the option to opt their kids out. We want to make sure that every parent has the opportunity to exercise that right. We want them to do it in an informed way. In 2023, we had some sort of weird misinformation stuff. So we would also love for you to just be good advocates for the survey if it comes up in your world, to talk about how this is a really important source of data for students. It's fully anonymous, so there's no way for us to track an individual student's data, and that we are very, very careful about how we ask those questions and the way that we ask them. So that is where we are at right now. I know people are always anxious for that data. Hopefully, because we have a lot more schools doing online administration than in the past, we will be able to get the 25 data to you sometime early mid-fall 2025. Any bias related questions? Awesome. Thank you all. Again, we're super excited with how many schools signed up just right off the bat this year, and that's really a great sign for us. So I will move us right into talking about school-based health centers. I think some folks know that, we came to you what feels like not that long ago, but is probably longer than I like to think about. Can you see big slides? So far, so good? Okay, awesome. So Penny Townsend and I are going to tag team. I'll let her introduce herself when we move into this next round. I will say, one of the things we were really excited to be able to do was to bring someone on Maine CDC who could really devote full-time attention to this program. And a lot of the really amazing work that you'll see here is due in large part to Penny being able to support these sites as they get up and running. We're really very thrilled about where we are at right now. So this is where we are. And Penny, why don't you just introduce yourself and then tell me when you want me to advance a slide?
Sure. Okay, so I'm Penny Townsend, and I am the school-based health center coordinator. So I work on Sheila's team, and I get the pleasure of dealing with all of the school-based health centers, not only the current school-based health centers to really get them kind of up and running, but also just kind of generating the interest in growing the school-based health centers and kind of all things school-based health centers. So this first slide just kind of shows a little bit about where we started back in 2021-2022 school year. We've had a few new providers, but the number and reach of school-based health centers has remained pretty much the same over the past 10 years of the program. And next slide. I know we're on a time crunch, so I'm going to talk kind of quickly, but we will have a chance for questions and answers. So we were fortunate to be able to collaborate with the Maine Department of Education and use some of that ESSER funding to expand the number of school-based health centers, adding new clinic sites in Midcoast with Lincoln Academy and Morse over in Bath, and also bringing on new providers to serve Augusta and Ellsworth. So with that funding, we did bring on some brand new school-based health centers, which was exciting, kind of some startup to really get them up and running. And then the next, yep. And so then this is where we are for this school year. With the new sites we added under ESSER, as well as new multiple school-based health centers who are engaged with the kind of the statewide school-based health center network that aren't actually receiving some funding. So we have had some kind of pop up on their own. Some have come out of the community schools, kind of a pitch to Julie and her team. Like for example, like South Portland Middle School, they were a community school. Old Town was a community school, and so they increased and showed some interest. Bangor really grew to both new middle schools. So these schools that you see highlighted have kind of come up with funding, which started from our funding. We get them started at one school and they've been able to use that to really grow to other schools, which is really, really exciting. Also, I just want to add that with these school-based health centers, not only have we kind of grown the number of sites, every single school-based health center has increased their hours of their medical provider and behavioral health provider services. So it's exciting to see, that they might have started out at 8 hours. Some of them now are operating full-time in the school. Almost half of these sites also are even open in the summer to provide services to students. So it really has increased the number of hours as well as the number of sites. Also, the spaces have really improved. I've been going out and doing some site visits this fall. Almost all of them that started out in a tiny little school nurse style office have grown into almost a full classroom that they've renovated into a whole health clinic. I just went to those 2 brand new middle schools in Bangor last year, and it's like you're walking into a full-blown clinic at a health center, like extremely impressive. So, and also many of them, not only have they bigger sites, but also more confidential sites. So they have an access point directly to the outside, so schools and families could just access it without walking through the entire school, for example. So really exciting stuff happening in the area of school-based health centers. The other thing that happened with some of the expansion funding is not only really marketing and the outreach for schools, but we also added a new service with dental. So almost all of these schools have also added dental services to students, and they continue to work on growing that initiative. And then I think Sheila's going to take it on with some data.
So we do track data for all of our all of the funded school-based health centers. Let me add that caveat. That map that Penny just showed you are the ones that get money from us, but also ones that don't get money from us. And we are really excited with the growth of sites that don't necessarily have state funding. It's really, that's one of the directions we've always wanted to go, but we are able to ask those folks who do have contracts with us to give us at least some basic data on the students they serve. So this is comparing the 22-23 school year with the 23-24 school year that, finished up. And a couple of things that I'll just sort of define. So enrollees are the number of our students whose parents or caregivers signed a consent form for that student to be able to access care at a school-based health center if they need it. All students being served by a school-based health center have to be enrolled by a parent or guardian unless they're able to, self-enroll for any reason. So that's sort of the biggest bucket of students, who are sort of in the, service group of school-based health centers. Users are the students who actually have a visit at a school-based health center for medical or behavioral health care. So those are the number of students who actually walk through the door. Medical users, pretty self-explanatory. They're getting care from one of our medical providers, usually a nurse practitioner. We do have some MDs and PAs. And then mental health users are seeing the licensed clinical behavioral health staff that are embedded within the school-based health center model. So if you look at that blue bar for the school year that just ended, a couple of things that are noteworthy, right? Just overall, more students being able to have access, and then more students actually accessing those services, particularly for medical users. And that's actually an interesting thing because Historically, we had seen much more growth in the number of mental health users, and we did see a little bit of a tick up in that. But it's really interesting that we're also seeing more students accessing medical care, which can be either for an acute health issue or for some sort of preventive visit, right? A risk assessment, a screening, or something like that. And that's actually going to tie into what Steph is going to tell you about a little bit later, because we think these two things are probably connected. Again, we don't know for sure why we're seeing more medical care now, but you know, there are a number of reasons. I think sometimes we're seeing that it's a little harder to get care in the community sometimes for students, or at least timely care. And so that's something that school-based health centers are really able to offer. So that slide before was the number specifically of young people. This is the number of visits. So this is the amount of overall care. And a student could come in for one visit for one thing, or they could come in for 10 visits for 10 different things. So this is just the overall amount of care provided in the school-based health centers. Again, more visits, which is awesome. Again, part of what we want to see is young people building relationships with the school-based health centers that will hopefully sort of really endure throughout their entire, you know, middle school or high school career. Again, a pretty noteworthy jump in the number of medical encounters, which is phenomenal. Again, we really want to be not just providing access again for students who need something, you know, sort of right away because they have a sore throat or a sprained ankle or any one of those issues. But we also want them to be seeing providers for those health risk assessments, screenings, right? We know though that is some of the care that tends to drop off for especially older adolescents at a time when really they need to be having those conversations with a provider. I want to make sure we have time for questions. I also realize I'm just like plowing right ahead. So please stop us. I really only have one more slide, and then I'd love to hear people, you know, any feedback or thoughts. This is again, big picture of sort of the who school-based health centers are serving. Don't worry so much about the individual little slices. I just sort of wanted to give you the 10,000 foot view. You know, school-based health centers really have a priority for serving students who may have less access to care in the community. And so we do serve higher number of students who are BIPOC students or students who are new Mainers. And so this is a really important source of care for those folks. As well as if you see sort of we about half of the students that are seen in school-based health centers have Maine care, you know, about a little less than a quarter, I mean, a third of them have a private insurance. But if you look at that sort of 16% and the 5%, that really represents students who are either uninsured or need a visit that is confidential, right? So they are seeking care for which they can self-consent based on statute. So reproductive health care, substance misuse services, you know, mental health. And all of our school-based health centers are very, probably, I would say probably even over cautious about making sure that if a young person is coming in for a confidential visit, that they are not billing that student's insurance because they're very aware that they don't want like an explanation of benefits or something like that to go home that might violate the student's confidentiality. All of the sites that we serve are required to provide care to students regardless of their ability to pay, and they are required to provide confidential care, again, according to Maine statute. So this is us, this is Penny, and this is me. We love talking about school-based health centers, if you haven't gotten that vibe. So they have, you know, and again, as Steph is going to talk about in half a minute, you know, they've been a really important partner for us in terms of sort of like kind of piloting clinical services for young people, either behavioral health or, you know, medical care. And so that's been really nice to both see the program expanding overall and also the sort of range of services provided within school-based health centers being able to expand and provide more kinds of care to more students, right, in more places. That's obviously going to be our goal going forward too. Questions about anything?
Sheila, want to pull your screen down?
Yes, I will do that. Questions, listeners? Again, huge shout out to our DOE colleagues who really worked so hard with us when we were sort of kicking off expansion. That really did allow us to kind of light a bit of a fire under the work that we were doing. And so we've, again, hoping to be able to just kind of ride that momentum here going forward.
Sheila, thanks for all the information. Really great to see you.
Absolutely. And like I said, you're going to see some stuff probably in Steph's presentation that may sort of like bring up some more questions about school-based health centers. So we're happy to tag team with Steph as she talks a little bit about another really exciting piece of work that we were able to roll out in school-based health centers around the screening, brief intervention, referral to treatment model. So I will step off the stage, and Steph, I'm assuming you're stepping up.
I sure will. Thank you so much, Sheila and Penny, for that really awesome tee up, and Anna for planning it that way perfectly. Really amazing. And it's exciting to see some of that preliminary data that I haven't seen yet, and to think about how that might link to some of the work that I'm doing and that I'm going to talk about. So let me just get my screen shared. Are folks seeing that okay? Can I just get a thumbs up? Okay, fantastic. So good morning, everyone, and thanks so much for inviting me to share a little bit about what we are calling the Maine Youth and Young Adult Screening, Brief Intervention, and Referral to Treatment Pilot Project. I'm going to give an overview kind of our year one summary implementation and take a look at some of that preliminary data today. I'm Steph Tucker, as Sheila already mentioned, working on the substance use prevention team on Maine CDC. We're also working really closely with the adolescent health and injury prevention folks, Sheila and Penny, who've been really awesome partners to me and very supportive of this work as well. So again, just to kind of give an overview of the day, the last little half hour that we have here together, we're going to review the project, take a quick look at implementation, dive into just a really high level overview of that data summary from year one, and then examine some next steps as well. And I do know that several of you were on the call for Opioid Coordinating Council yesterday. This will be a little bit of a review, but my hope is that there might be other questions or considerations that come up as you hear it a second time. And I see lots of new faces on here as well, which is really exciting. Okay. So to start with just a little bit of background, in 2021, the Maine CDC's Tobacco and Substance Use Prevention and Control program just recognized a gap in our prevention work. So ultimately, our goal with adolescents is always to delay the onset of alcohol, commercial tobacco, and other substance use as long as possible. But our youth survey data demonstrates that young people are using substances for a variety of different reasons. And we decided to explore some opportunities for expanding those preventive screenings in school-based settings, as Sheila mentioned. And we did so as a tool to kind of identify those early risk patterns. And we did so in collaboration with multiple offices in Maine's Department of Health and Human Services, and developed a plan which included hiring a project coordinator, ended up being myself, and conducting an in-depth needs assessment to just gain a better understanding of what that current SBIRT implementation looked like in Maine at the time. So we worked with an external evaluator to complete that environmental scan in 2022. Elements from a lot of similar programs in Washington State, Colorado, and Massachusetts were all pulled from for the development of the protocol that we ultimately implemented. And as part of that process, I also met with multiple partners at the state and community level to just better understand what those existing adolescent substance use resources really looked like in Maine. And some of that effort was focused on building a specific resource directory for youth-based treatment providers in counties that had at least one school-based health center. All right, and based on the results of our assessment and planning stages, these are the objectives that we developed for the MySBIRT project. So implementation of SBIRT in school-based health centers, overall integration of motivational interviewing, across the board improvement in training and technical assistance opportunities, that crucial expansion of behavioral health staffing hours, and then of course, the support and data collection and evaluation to really inform the feasibility and transferability of SBIRT in school-based settings. And so some of you on the call may already be familiar or have a foundational understanding with the fact that SBIRT is a comprehensive and integrated public health approach that's implemented in a variety of settings to provide those opportunities for early intervention with folks who might be using substances or those who are at high risk for substance use down the line, specifically before those more severe consequences and long-term addiction occur. So screening quickly assesses the severity of substance use and identifies the appropriate level of intervention or treatment. That brief intervention component is really focused on increasing individual insight and awareness regarding that substance use behavior and start building motivation towards change. And then the referral to treatment component is for those identified as needing more extensive treatment, making sure that they have access to that specialty care. Okay, we're gonna dive into talking about what that first year of implementation looked like. So in the spring of 2023, we did secure funding from the state's Opioid Prevention and Treatment Fund to offer funding for school-based health centers to participate, and at the time, a one-year opportunity for this particular project. It was limited to schools that had a school-based health center, although that prior state funding was not a requirement. And just in the interest of time, I will go ahead and drop the comprehensive list of schools who participated in the chat at the conclusion here or follow up with the notes. But as a provision of funding, pilot sites had to agree to conduct SBIRT verbally with students ages 12 and up enrolled in their school-based health center, commit to increasing overall student enrollment with the understanding that only students who are enrolled are going to be participating in that SBIRT project, utilize specific frameworks for positive reinforcement and brief intervention, provide school-based treatment and make appropriate external referrals as needed, and then again, collect that aggregate data using a provided data collection tool that we created at the state level for this particular project. And the protocols, activities, and requirements documents really provided guidelines for utilizing each of those brief intervention models to address the student screening result. But REACT stands for Reinforce, Educate, and Anticipate Challenges of Tomorrow, used to positively reinforce non-use reported by students. And then the brief negotiated interview is that framework for eliciting kind of current motivations for change using those classic motivational interviewing techniques. And so referral to treatment is an area that we tried to think about really intentionally. I think most of us working in primary or secondary prevention know that Maine is limited in its substance use treatment options across the board for both adults and adolescents, particularly so for younger folks. And the screening tools and brief intervention frameworks that SBIRT embeds provide some of those guidelines around when it's appropriate to make a referral to treatment. But again, kind of to some of what Sheila talked about, protecting confidentiality while kind of capitalizing on those individual motivations is really difficult in a clinical setting. And I'll be talking a little bit about what the treatment components look like for students during this pilot in a couple of slides. But the cool thing is that school-based health centers are in a really strong position to meaningfully engage students in a variety of treatment options that are appropriate for their reported use. School-based health centers can follow up with additional visits, potentially make internal referrals to counseling, and support those warm handoffs to external providers when needed. And again, to Sheila and Penny's point, those relationships cultivated by the school-based health center providers are super critical in boosting those linkages between the adolescent and potential resources for making overall healthy choices about substance use or other areas of health, and is bolstered by that integration within their environment. Okay, we're going to hop into a quick data summary. I think it's really important that we just acknowledge the limitations of this particular pilot study. I will make sure that these slides are made available to Anna to send out with the notes so you have some time to kind of look everything over at your leisure, and I'm happy to follow up with any information that you might have in response to questions here. But just as a reminder, the following slides are going to include information in aggregate, meaning that it's a compilation of the data summaries from all 3 participating sites. And it's also important just to restate that since it's a pilot in its initial year. We can't compare information year over year or make any causal conclusions about what this information is telling us. But what we can do is kind of examine and discuss some of the interesting things that we're seeing from that initial iteration. And I do also just want to mention that there will be a few slides where data has been suppressed to protect confidentiality, and that is based on CDC's best practice when less than 10 respondents responded under a particular answer. So in the first year of the pilot, our 3 school-based health centers screened a total of 386 students and made 50 follow-up referrals, with the majority of those screenings occurring for students in grades 9 and 10. An additional 21 students who were eligible to receive this screening opted out during the required verbal assent. That was a provision under our institutional review board approval that students be given that option to opt out. 2 out of the 3 schools that participated were able to screen all students who were in their school-based health center as well. So once students consented to the screening, the provider proceeded with these pre-screening questions. The exact wording is listed on the screen here for you. And we selected the CRAFT 2.1 plus N screening tool. And I'll talk a little bit about why in just a couple of slides. So of the students who identified that they used any substance on 1 or more days in the preceding 12 months, the percentage of use reflected by the 3 sites were 9.07% for both alcohol and cannabis, and 8.81% for commercial tobacco and nicotine products. And when we look at these graphs, it's important to remember that since we received data from each site in aggregate, we can't specifically identify any co-use behavior. So the percentages of students who answered positively for each substance could be the same students across all of those substances. They could be all different students, or they could be a mix of students reporting both co-use and use of a single substance. And just to kind of call this out proactively, these figures are significantly lower than the 2023 Maine Integrated Youth Health Survey numbers for these substances. And again, we can't confirm necessarily exactly why this is, but some of the considerations that we had were the fact that MIAS is an anonymous self-reported survey where there isn't any expectation that somebody is going to have a follow-up conversation with that particular student about their responses, whereas SBIRT at its core is inherently meant to be an interactive and collaborative process. So that might be where some of that discrepancy lies here. And so when looking to compare substance use results, we took the total number of days for all students who reported using a particular substance in that past 12 months, and then determined the average number of days each individual student used that substance. So of the 9.07% of students who reported 1 or more days of alcohol consumption in the past 12 months, the total number of days of consumption across those students was 308, with the average number of individual use being 8.8. Of the 9.07% of students who reported 1 or more days of cannabis use in the past 12 months, the total number of days of use across those students was 4,350, with the average number of days for an individual being 64.09. And then of the 8.81% of students who reported 1 or more days of tobacco or nicotine use in the past 12 months, the total number of days of use across those students was 4,350, with the average number of days being 124.29. And so again, this is raw data from a relatively small sample size, but it's interesting to consider that even though the percentage of students who reported 1 or more days of use for alcohol, commercial tobacco, or nicotine and cannabis were fairly evenly spread, the frequency of that commercial tobacco and nicotine use was reported at higher rates among students who screened positive. And again, we can't say for certain why this is, but some of the possibilities we considered were the fact that commercial tobacco and nicotine use, specifically vaping, tends to be a daily use substance versus something that might be used more socially, like at parties or with friends. If a student screened negative for all questions on Part A, the provider followed up by asking just the C question in CRAFT, which had to do with have you ever ridden in a car by someone, including yourself, who was high or had been using alcohol or drugs, and then responded with either positive reinforcement, or a plan for safety if a student reported that they had ridden in a vehicle with somebody under the influence. And then if a student screened positive for 1 or more days of use to questions 1 through 3 in Part A, the provider was prompted to ask the student all the questions in the craft, which resulted in a score between 0 and 6. And so since students were self-reporting, right, it's possible that a student reported use in Part A, but still received a craft score of 0. And since all students screened in this pilot were under the age of 21 and couldn't legally purchase any adult use products, providers were directed to give a brief intervention regardless of any of Part B or Part C scores. And so of the students who screened on Part B of the craft, the percentages who responded yes to each question are shown here on this slide. Based on student responses, students were more likely to respond with a yes to using substances to relax and to using them alone than yes to other questions, with 67% and 48% respectively. Additionally, 15% reported that they had ridden or driven in a car with someone who was high or had been using alcohol or drugs. 21% reported that they had forgotten things they did while using alcohol or drugs. 19% reported that they had a family or friends tell them that they should cut down on drinking or drug use. And 21% reported that they had gotten in trouble while using alcohol or drugs. And so this graph reflects the percentage of students who received a specific score on the craft, so not a cumulative one, specifically a score of 1 or 4 versus 1 or higher or 4 or higher. And so 80.42% screened negative for substance use across the board, including that response to riding in a vehicle with someone else under the influence. So based on the information we received, all students participating did end up being screened with Part B of the craft, which accounts for that 0 response being so high. And it's also important to note that in Part A, students are just reporting a yes response to whether or not they've ever tried a substance and identifying how many days that substance was used, whereas this distribution is asking more about individual motivations and behaviors that tend to be subjective, which may have influenced kind of that distribution as well. Students who answered 1 or more days in response to using a vaping device containing nicotine or flavors, or use of any commercial tobacco products on the Part A pre-screening, which was question 4, were then screened with 10 questions about tobacco products in Part C. And those questions are reflected here for you. You're going to notice right off the bat that a portion of the responses in Part C did have to be suppressed. Overall, less students were screened in Part C, so it's even harder to make clear connections in this section. But of the students who reported commercial tobacco or nicotine use in the previous 12 months, 62% of students identified that they've tried to quit but couldn't. 63% of students identified that they use commercial tobacco or nicotine now because it's very difficult to quit. 50% identified that they felt like they were addicted to vaping or commercial tobacco. 45% identified that they have had strong cravings to vape or use. And 34% identified that they felt like they really needed to vape or use tobacco. And so it's interesting that although 50% of students who screened positive in this section reported that they felt like they had a nicotine use disorder, less said that they felt like they really needed to use or had difficulty not using. And so some of the considerations we had around why this might be is that it could possibly be influenced by the way the questions are verbally formatted, overall internalized shame about use behavior, or fear of consequences based on those responses. And then additionally, that question 7A through 7D is associated with specifically stopping or refraining from use. And it's possible that there were fewer responses there because students who screened positive had never even considered trying to stop. Based on those student responses to Part B and C, providers then recorded what actions were taken or if any follow-up referral was made. And the way we delineated that on our data collection tool is listed here for you as well. Based on the trajectory of 1 or more brief interventions conducted with the student, the school-based health center providers then selected an appropriate treatment referral from a drop-down menu consisting of the following: in-school counseling, following up with the school-based health center provider, the student intervention reintegration program, which is an alternative to suspension program, outpatient provider referral, other, or none. And it's important here to just remember that following kind of that full treatment trajectory for students that received a referral was beyond the scope of this project. However, based on the small number of students who needed a follow-up referral at those 3 pilot sites, school-based health center providers reported that there were adequate resources available to meet that need, which is really exciting. And then this graph shows actions taken. So 86.72% students received positive reinforcement for non-use. And this aligns with other state and national data that suggests, majority of students or adolescents are not engaged in substance use. And then 37.5% each received a brief intervention and referral. And this is really exciting to me as a project coordinator because it means that every student who received a brief intervention was referred to some type of follow-up, even if that was just as simple as receiving a follow-up visit with the provider. And again, I think this kind of speaks to and reinforces the benefit of that relationship building and accessibility piece that Sheila and Penny have been talking about that's kind of built into that school-based health center model. These next couple slides, I know we're coming up to time, are just pulled together from the qualitative reports that our sites completed. And again, are intended to just help inform the feasibility and transferability of SBIRT in school-based health settings, but also in other clinical settings that serve youth. So of note for successes, all sites grew their enrollment as is reflected in Sheila's presentation as well. One school updated their substance use policy from a 0 tolerance to a more restorative approach. And the project has provided an overall opportunity for positive relationship building with students, hopefully impacting some of those protective factors and that connection to school and caring adults, which, in primary prevention is something that we're always focused on building. Some of the challenges that we faced in this initial year were overall difficulty motivating students to take the screening. It was a voluntary process. There were reports that sites had some really great successes with some contingency management, both with getting students in the door and also with kind of some of that follow-up treatment, which was really exciting, to be able to have relatively unrestricted funds to be able to support some of that innovative work. Staff turnover, both at the school-based health center, but also just at the FQHC or kind of primary care provider location. And then the perception that students may not have always responded honestly to screenings. Overall, some of the qualitative takeaways that we identified were needing to figure out how to integrate screening into existing electronic health records while still being able to protect that confidentiality. Identifying that administrative support was vital to implementation across the board, both at the school-based health center level and also, with their partner organization. The need to figure out a way to adapt the protocol to each individual site, improving overall education efforts to ensure that the adolescent patients are aware of kind of those expanded Maine minors' rights protections around consent for substance use treatment in Maine. And then I think, something that's has come up again and again in multiple different spaces is just the understanding that SBIRT really requires sustained funding outside of those reimbursement only models to be implemented consistently and successfully. That's something that we heard over and over again. In terms of next steps, all 3 of our year 1 participants have signed on for a second year of implementation. And we have also been able to add 3 additional sites. Again, I mentioned that initial year was funded through the Opioid Prevention and Treatment Fund. The second year has been funded with some remaining American Rescue Plan Act funds and supplemented with some tobacco funding. And we do hope to recruit at least 2 college health centers to pilot SBIRT. I'm currently developing a protocol for implementation with that young adult population, so focus on 18 to 26. And we'll be seeking institutional review board approval for that as well. And part of my role in this initial year has really been thinking about what tools the public health field at large needs to be able to implement quality SBIRT to fidelity, which is included considering ways to improve and streamline those opportunities for training and technical assistance. So this summer, our team partnered with a local expert to create an orientation video aligned with this project that was shared with pilot participants and is available as a resource to support school-based screening. And we actually just finished filming a series of brief intervention demonstration videos using the React and brief negotiated interview frameworks with our training partner AdCare and one of our own staff members. And these will be shared with providers and other interested partners sometime in December. And again, are intended to support our pilot participants in conducting those best practice brief interventions using the spirit of motivational interviewing. And then finally, our team has been actively exploring some longer term data collection solutions that would alleviate some of the challenges around the current process and move towards overall sustainability for this project among school-based health centers. So I have a ton of additional process documents that I'm happy to share if anyone's interested. I had a lot of great engagement yesterday after the Opioid Coordinating Council meeting. So please feel free to reach out to me with any follow-up. So appreciate your time and attention to this work and just for your invitation to share today. It's a project that I've been really passionate about. I think everybody else on our team, our substance use prevention team, but our TSEPC team at large has really recognized as a value add to school-based services, and just really appreciate the opportunity to share about it in this space today. So thank you so much.
And Steph, we are at time. If folks, we can let folks go, but if anyone has any questions, please feel free to chime in if you want to stay on a little bit longer. And Steph, I don't know if you can stay on a little longer to answer.
I can, yes.
Great.
And Steph, I did put the sites in the chat.
Oh, thank you so much, Penny. I appreciate it.
Yes, all the sites are in the chat, and I will send those out as well, along with the slides following this time on meeting. Great. And Steph, I know you're available if folks do have other follow-up questions.
I sure am. Absolutely.
Thanks, everyone. A lot of information. We will see you in January.
Thank you all. Good to see you.
Thank you.